Welcome to HealthLine season finale. I'm Fabiola Zavala. In 2004, 9% of adolescents aged 12 to 17 experienced at least one major depressive episode in the last year. To talk to us about this and other behavioral health issues, we'd like to welcome Dr. Anthony DeJoseph, Executive Director of the Behavioral Health Services Department at McNeil Hospital. Welcome, Dr. DeJoseph.
Thank you.
So I mentioned that approximately 9% of adolescents in 2004, aged 12 to 17, experienced one major depressive episode. Of those 9%, would they receive treatment for that depression?
Well, one of the things I'd like to say first is that depression as an illness is one of the most serious health problems we have in the United States. And throughout all the age ranges, we have a difficulty, and that's that depression is under-recognized and under-treated. And it's no different for children and adolescents. In fact, it might be a little worse in terms of recognition and treatment. Of the population you're mentioning, probably less than half ever get recognized and get any kind of help at all. The problem is that this leads to some other serious issues if untreated, perhaps the potential for the illness to become more regular and permanent and to recur and become more a part of ongoing life. Certainly there's severe consequences that you have to worry about in terms of suicidality, which is a common symptom of depression, all too common and obviously very dangerous symptom of depression. As in other age ranges, we have a problem with recognizing it. I think the error we see sometimes is that we attribute it to developmental stages. So we say it's just a part of the teenage years that are very turbulent, but that's quite untrue, actually. They don't have to be, and it's actually a small percentage of adolescents that may go through depression. It's oddly enough at the end of life, although we're not talking about older people, but we have the same problem there. We attribute it to aging. So I think we have a tendency to deny this somewhat as a culture in terms of recognizing depression and also accepting that it has to be a normal part of developmental stages, and it doesn't have to be, and it shouldn't be, actually.
Okay, at some point does this issue become more prevalent among one gender than the other?
At adolescence, there's a differentiation in the occurrence, the incidence, where it seems to become more prevalent in females, on the order of perhaps 2 to 1, whereas before adolescence, pre-adolescence, there's not a differentiation that we can define.
Okay, is it also more prevalent in children or in adolescents who have other psychiatric disorders?
Yes, I think that other kinds of psychiatric disorders or psychosocial type problems may certainly leave one either more susceptible to depression or may aggravate a predisposition to depression. Many of the problems that may occur in adolescent populations, such as the potential for substance abuse, might have a relationship to depression as well. And the issue of how depression comes about as related to these problems, if you take one example to make it pretty concrete, you may have someone who abuses substances, and if it's a person who has a predisposition, in other words, an inherited predisposition to perhaps having depression, using a substance may precipitate that. It may precipitate it where it may have never happened, or it may precipitate it where it comes on earlier than it ever would have, or it may make it more severe than it would have just given the predisposition. So yeah, the relationship between depression and substance abuse and depression and other psych disorders is pretty clear. And as some other psychiatric disorders actually have depressive type symptoms as part of their symptomatology as well.
Okay, so it can be psychiatric disorders, or it could also be general medical conditions like those adolescents suffering either from cancer or diabetes.
Well, definitely, someone suffering from major illnesses, there's always a risk that they may react to these traumas with depressive symptoms.
Okay.
And which brings up an interesting distinction, because you can have depressions that are caused by your environment, traumas such as becoming very ill, losses, that sort of thing in your world. But also we certainly believe that a large proportion of people who have depression also have inherited it. It's a passed down illness as well. And those depressions can be very different. The one caused by your environment and problems that you encounter there, hopefully could be a shorter length, perhaps a single episode. You can recover differently. The ones that we believe are biological might be a more lifelong proposition to deal with and take care of.
Okay. What are some of the common symptoms of depression among adolescents that we should be aware of?
With adolescents, as opposed to children, the symptoms are not too dissimilar from adults. You'll have feelings of hopelessness, helplessness, loss of interest in things that may have previously interested them in life, loss of pleasure in those type things. You'll certainly, it may be different in adults because we're not still in school, an academic decline is very common with depression, at children and adolescent age ranges. There'd be a dysphoric set of feelings, and generally not experience a lot of happy feelings. There may be withdrawal from others and a real decline in social relationships as well, and activity. And certainly, again, we worry about the fact that suicidal ideation and behavior can often become a part of more serious depression.
Okay. Now, would the symptoms be different in younger children than those in adolescents?
Generally, they seem to be, there is a preponderance in just a more narrow set of symptoms that we see, at least that they display. There may be more going on underneath than you can recognize easily in children. But what we see with children with depression is that there tends to be aggressiveness, lots of crying spells, and probably in this group more than others, it's somatically expressed. In other words, there's physical complaints. Or maybe not complaints, but they're saying all the time that they have stomach aches, headaches. Those are the two biggest. And the presentation seems to center more around those more limited kinds of things, at least that we can recognize. And children may be, younger children may be certainly less apt to be able to describe feeling type issues and all than than adolescents. So that seems to be the major difference. Now with children, there may be suicidality that's not as clearly expressed. And an adolescent, they may actually, talk about wanting to end life and feeling suicidal. But with a child, it may manifest itself as more just extreme self-destructive kinds of things.
We're back talking to Dr. DeJoseph. We were just talking about the symptoms of depression among adolescents and children. And Dr. DeJoseph, how likely or what is one of the outcomes of depression that we talked about, suicide? Can we talk a little bit more about that?
Yeah, I think that suicide as a result of depression should really prompt us to get better at recognizing and taking seriously symptoms that may be seen by family and parents and all, not dismissing them as a phase that someone's going through. The fact is that suicide as a cause of death in adolescence is actually very high, ranking with the top few causes of death in adolescence, thereby just kind of forcing us that we really should take it more seriously than we do and have better efforts at recognizing it.
Why don't we go through some of the symptoms again that we should be aware of and looking out for among adolescents?
Okay. Well, if you see withdrawal from normal activities and relationships with others, a change in that. If you see a person's mood and affect always being kind of flat and lacking any kind of positive feelings. If their appetite, I don't think we mentioned this before, or their sleep changes, that could be in either direction. Some people may react with eating much less or not eating at all if they're severely depressed, or some others may react by eating more excessively. And sleep could change to the extremes as well. Someone could sleep excessively whenever they get the chance, round the clock, may not get up to do much of anything at all, may not even leave their room. Or there could be a severe insomnia as well, where a person has difficulty getting any sleep and may sleep 2 hours a night, and that's all they can manage to sleep. So the extremes of appetite and sleep are something to look out for as well. Certainly there's a high incidence of misguided efforts to cope in some ways, and sometimes they may choose drugs or alcohol to attempt to alleviate symptoms of depression too. As a matter of fact, drugs and alcohol can be used to try to alleviate other psych-type symptoms, and it isn't an uncommon thing at all. But with depression and adolescence, we may see that they, attempt to soothe these symptoms with those uses too. And then academic decline is usually a pretty early thing that may occur in the evolution of depression. So if that's noticed, certainly we could be concerned that it might be an emotional issue leading to that rather than others.
Okay. And what are some of the treatment options for adolescents or for children with depression? If a parent or a friend notices all of these symptoms, what should they do?
Yeah. Well, there's basically two ways to approach it. One is the use of psychotropic medications, antidepressants, and in current day we have medications that are quite effective and quite safe compared to decades ago. We've really evolved a group of antidepressants that are more specific, and they have very little risk and very little side effects. So antidepressants may be a treatment of choice, certainly. It depends on also the severity of the depression and the origin of it. If we're really suspecting it's a more biological type depression. For instance, if we know that parents and grandparents had severe depressions, we may suspect it's biological, certainly, and we may certainly choose to use an antidepressant medication. If the severity is less and we suspect it is more reaction to a trauma or a loss or something of this nature, we may go and approach it with psychotherapy, counseling type services alone to see if that's effective. In some cases, we want to use both. And as a matter of fact, it's been proven that with many psychological problems, that the combination of psychotropic medication and psychotherapy is more effective than either alone. So I think those are the options, and I think that it's real important to get a professional opinion when we suspect that our child or adolescent may be suffering from depression, and follow through with the treatment. So those are the options, except if depression is severe enough for it to be life-threatening and the risk being high. In the most extreme circumstances, someone may have to be hospitalized to protect themselves from harm if they're really intending to hurt themselves.
Okay.
Thankfully, that's a small percentage of the cases.
Good. How likely is the depression to carry on into adulthood? Is that very common?
It is common, and again, it's probably about half of the cases we may have to worry about recurrence in later life. And unfortunately, sometimes depression can be a lifelong illness. Someone will have to take care of lifelong, take medication for, and continue to see professionals for.
Okay. Now, another behavioral health issue that's very common among, if you can tell us how common it is among adolescents, is something that we hear about. It's called cutting. What exactly is cutting?
Well, cutting is a form of self-injury where someone will use sharp objects, blades or other types of things, to cut the skin superficially. Usually it's done numerous times, and it's a fairly common type of self-injury. Self-injury as a whole isn't a terribly common thing as a psychiatric problem, psychological problem, but it's certainly serious enough to be concerned about, and it could be a rather kind of a difficult problem to deal with in terms of getting someone to stop. And there can be serious consequences even if the person doesn't intend serious consequences. There's other kinds of self-injury. Cutting's probably the most common. Burning oneself with cigarettes is another, and that's a fairly common one as well. Probably the top two would be cutting and burning with regard to self-injury.
Okay, and because we're hearing a lot more about it, do you think that that's one of the reasons why adolescents might be curious to try it, or?
Well, I would hope that no one, tries it out of curiosity, but I think that, it could be portrayed in a real misguided way by peers or even by the media, or could be construed as something that might be cool to do because you're tough or you're able to withstand that, or maybe a counterculture kind of a thing. So I suppose it could be tried that way, but I think the truth is that it's usually resorted to by individuals who have some very serious emotional pain underneath. It's an attempt to cope, and it's a misguided attempt to cope. It's not an adaptive coping mechanism at all to cut oneself in reaction to pain, serious emotional pain internally. It doesn't resolve it. It kind of just detracts your attention from your internal emotional pain to the pain of the cutting. The problem is that the emotional conflict and pain is going to come back because it's not an adaptive coping mechanism like talking about your problems and trying to find resolution, trying to understand them and trying to find resolution to them. Okay. Cutting can become a compulsive thing because during that time it may actually offer some kind of a sense of relief from severe internal emotional pain, because it just takes your focus and puts it on the physical pain. Okay. So it can be felt as an escape, but it's a momentary escape, and it can progress to the point where it's very harmful and damaging very quickly.
We're back with Dr. DeJoseph talking about cutting. Dr. DeJoseph, can you tell us why this is sometimes brought about? Is it usually because of a traumatic experience among children or adolescents?
We often find that there is some history of serious trauma in early life in the histories of people who cut. So they may have been dealing with a rather lifelong serious issue, maybe not dealing with it, and then maybe the first attempts at dealing with it are cutting to try to relieve pain. These traumas are often some type of abuse, whether emotional, physical, or sexual abuse. So we find that there are often rather pretty serious histories in the people who end up with significant cutting and self-injury of other sorts. The other problem is that there can be more severe consequences with cutting than the person even intends. When you're cutting, there's risks of infections of all sorts, And the other issue is that sometimes people cut deeper than they intended, and there are at times kind of accidental suicides via cutting as a self-injury. And we have to be concerned about that as well.
Okay, so someone who's experiencing this, what should they do? How should they get help?
Well, cutting as a self-injury is an interesting thing because one of the very prominent symptoms is covering it up, literally and figuratively covering up the injury so no one sees it and really hiding it as a behavior. So it's difficult for people who are cutting to admit it. And this is one of the first things they have to contend with in getting help, is to be able to admit it to someone else and then ask for help for the problem. And it may be a very misunderstood thing by anyone that they ask for help, and they may kind of shy away from helping someone deal with it because it can be seen as kind of a very bizarre behavior to cut one's body like that. And if that happens, they need to just continue to ask adults for help somewhere at school, counselors at school, teachers, parents, wherever, till someone takes it seriously and assists them in getting help. So admitting it and asking for help, and then following through with the counseling that most likely will be recommended for it, because often it's not an issue that's going to resolve easily. It has to be dealt with. There isn't really medication for cutting unless it's related to another psychiatric disorder, so the treatment of choice will often be psychotherapy.
Okay. Another issue that is very common among teenagers is the use of drugs or substance abuse. Can we talk a little bit more about that?
Sure. Well, I mean, the war on drugs failed. I don't think there's any less incidence of drug and alcohol problems and use these days than there was in any past decades. It's a very serious problem among child and adolescent populations. We have seen a trend in terms of the only recent change is not a good change. It's creeping down earlier in the age ranges at a significant rate. Otherwise, the incidence isn't getting less. The choice of drugs may change a little from time to time, but there still is a very serious incidence of drug and alcohol use among children and adolescents.
Now, is there a relationship between the use of drugs and violence among?
There can be, and while that's a real correlation, I do think that sometimes it's portrayed as always a symptom, or always a behavior that's related, and that's not necessarily so. Everyone that uses drugs or alcohol doesn't become violent, but the fact that there is a subpopulation there that does, whatever the causal relationship is of concern as well. And the aggression and violence can lead to dire consequences for the person who is behaving that way, certainly.
Okay.
They can expose themselves to much more risk in terms of aggressive behavior, where they display that, who they display it with, could get themselves and others hurt, certainly, or worse.
Now, are those teenagers that use drugs more likely to attempt suicide?
There is a much higher incidence of suicide, successful suicide, in drug abusing or addicted adolescent populations than the general adolescent population, or non-using, non-addicted adolescents, definitely.
So how should teenagers learn to turn down drugs or stay away from them?
Well, I mean, just say no is seems like sometimes a too silly and simple a proposition. But it should be what is used, but it's as a result of lots of education about. To say to someone, just say no, without giving them all the information they need to understand so that they'll want to say no, isn't going to work. A lot of education about the effects of use, especially during development, certainly might put someone in an educated position to refuse drug use when offered, and refuse the intense peer pressure to use that there's going to be in these years.
And it's the parents, and it's the teenagers, and it's the school environment, correct, that should be educated? And
yes, it's best to start with this from very early ages. It's never too early for the parents to be addressing this with children. at all. I mean, it can be done from the point where they're verbal on, and to kind of inoculate and build up a resistance to prepare the child for the fact that it's going to come up in their environment. And if they have an understanding already that it's a damaging thing to their life, their body, their development, and their future, they've been prepared for this for a long time, there's a much better chance of resisting peer pressure and actually saying no. So there's a lot more behind saying no than just teaching that simple phrase.
We'd like to thank you, Dr. DeJoseph, for being with us today. I'd like to thank you for watching HealthLine. I'm Fabiola Zavala. Until next time.